My name is Beth Springate. I'm one of the neuropsychologists at UConn Health, and I live really in that intersection between brain and behavior. So in my clinic, we see a number of folks who have cognitive issues, so changes in memory, attention, concentration, for a number of reasons. So things like strokes, head injury, multiple sclerosis, even in the context of, for example, significant severe mental illness or alcohol and substance use. But my passion has always been older adults. So I'm going to talk today a bit about cognitive aging, dementia, and caregivers. Just a bit about myself. I did all my graduate work here at UConn, so I got my master's and PhD here. And then I went to Brown for my internship and postdoctoral training, and I worked in a rehab hospital for a few years before I came back to UConn, I guess 10 years ago, 2016. And I currently serve as the director of neuropsychology here at the hospital. So as I mentioned today, what I really want to do is spend some time talking about normal aging. So just what do we all experience cognitively as we get older versus some of these more pathological changes. So things like MCI, dementia, some of the main causes of dementia with a focus on some of the neurodegenerative conditions, and then also the effects on caregivers and caregiver burden. So when we think about normal aging, as I'm sure all of you guys know, the US is an aging population, right? The number of older adults is really expected to increase quite a bit over the next few decades. The graph on the slide really focuses on folks 80 and up, but in general, right? So the number of folks 65 and older is really expected to increase by about 30 million folks by the time we get to 2050. And particularly, we're seeing the most changes in this older group, this 80, 85 plus year old group. When we think about cognition, we know 10% of those age 65 and up have dementia, but that really increases quite a bit as we get older. So age is the primary risk factor for developing dementia. And by the time you get to 85 and up, about half of folks have dementia. So when we think about normal aging, there are a number of changes that occur in the brain, just like the body as we get older. And I'll kind of walk you through a few key things. So when we think about intellectual skills, right? These things are not really expected to change over time. When we think about really accumulated knowledge, accumulated skills, all the things you've learned over the course of your lifetime. What can be a bit more difficult is what we call fluid intelligence. This idea of flexible reasoning, thinking, problem solving can become more effortful and inefficient as we get older. Memory, we know that our recall of information stored over many years, so past events, key things from our lives, conversations, remains intact. Same idea with procedural memory. So your ability to remember how to do things like ride a bike, tie his shoes, those things are not expected to change as we get older. What does change a little bit is forming new memories, particularly the efficiency at which we do that. So it's not that older adults can't learn new information, but they're not as quick at it. So they may need a couple of extra repetitions to really lock that information in. Same idea with memory retrieval. It may not be as efficient. It may be a little bit slower to pull out that memory. And some folks may need a couple of additional cues or reminders, but that information is still in there. When we think about attention, our ability kind of moment to moment attention, what we think about is like simple or focused attention is just fine. What changes as we get older is ability to really divide our attention amongst multiple things at the same time. This idea of multitasking or even selective attention, right? Paying attention to one thing while sort of trying to ignore other distractors in the environment. That becomes much more challenging. When we think about language skills, these generally are pretty resilient over the course of aging. So our verbal abilities, vocabulary, grammar, spelling, all those types of skills remain intact. The one thing we do notice is that sometimes word retrieval can be a bit slower. There's a bit of a hesitation sometimes to pull some of these words out. When we think about executive skills, some of those higher level reasoning, problem solving abilities, when we ask older adults to reason about familiar materials, kind of metacognition, thinking about thinking, or decision making and the quality of their decision making, we don't see any of those changes. What can be more challenging is inductive reasoning, like looking for new trends, new patterns, using new methods to solve old problems, even things like multitasking. Speed, unfortunately, declines as we get older. There's really nothing much we can do about that. And then spatial skills, our ability to perceive the world, size, color, distance, relationships between objects, no changes there. What can be more difficult is this idea of spatial navigation, right? Sort of imagining you've been plopped in the middle of a map and how do I imagine how to get from A to B? Mental rotation, what would this object look like if I turned it 90 degrees or 180 degrees in space? These types of things become more effortful as we get older. And this is obviously because our brain is changing, right? So as we get older, generally speaking, there's generalized atrophy, a generalized shrinkage of the brain, particularly in more of the prefrontal, parahippocampal regions, which are important for a number of these skills that we talked about. We also see changes in white matter. And white matter is really that connective tissue that, connects part A to part B, really is that information kind of highway that allows the brain to communicate within itself. And so it's really these changes in circuitry that are driving a lot of the changes that we notice with normal aging. We see development of neurofibrillary tangles, beta amyloid accumulation, and even kind of changes in the dopamine system as we get older. Now, when we think about pathological aging in the brain, dementia always comes to the forefront. And we know, like I said earlier, the age or the risk for dementia doubles every 5 years after age 65. There are a few kind of big genetic risk factors for dementia. So ApoE, presenilin genes, a lot of these we talk about in the context of Alzheimer's disease are risk factors for development of these dementia syndromes. Demographically, so we know that lifetime risk for women is higher than that for men. We also see greater rates in Black and Hispanic individuals. This figure on the right came out about 5-6 years ago, and I think has really been an interesting way to think about dementia and really has kind of changed the field a little bit. And I use this or things like this quite a bit with patients when I work with them, really talking about some of these potentially modifiable risk factors, lifestyle, that can impact our risk of developing dementia down the line. So whether it's things like related to early life, like education. So we know that folks with greater levels of education have a lower risk of dementia. We know midlife factors can play a role. So things like hearing loss, head injuries, not concussions, but more significant head injuries, hypertension, other kind of medical risk factors, alcohol use, obesity, all these types of things play a role. Just like things in later life too, depression, smoking, social isolation, physical inactivity. There's been actually a couple of kind of newer studies looking at air pollution. Folks who live near highways, industrial areas tend to have greater risks for dementia as well. So when we think about diagnosing cognitive disorders, they really break down into two buckets. We have this mild cognitive impairment or minor neurocognitive disorder bucket. And we have a second bucket called dementia or major neurocognitive disorder. When we think about mild cognitive impairment or MCI, what this really is kind of cognitive changes that are in excess of normal aging, but don't impact someone's day-to-day. So they're still able to live independently, function, do the things that they need to do. Sometimes you might see some subtle changes. So maybe they're a little bit more reliant on their calendar to remember to go to an appointment or to pay a bill, more reliant on, that phone alarm to ring and kind of cue them to take their 9 o'clock medications. But they're living independently, they're doing well. Oftentimes, this is seen as sort of a transitional phase between normal aging and dementia, but folks with MCI don't always progress to dementia. About 10 to 15% folks convert per year. It's higher than the normal population, but again, there's a fair number of folks who just maintain this MCI or minor neurocognitive disorder diagnosis. We also think about dementia, major neurocognitive disorder. So this is when someone's experiencing changes in their cognition in multiple areas, so memory plus attention, attention plus executive skills, and it's impacting their ADLs. They need help with their finances. They're having driver accidents. They're missing their medications. And there's a number of things that can contribute to this, right? So on the right side of the screen, we kind of have the pie chart. The most common cause is Alzheimer's disease, but there's a lot of other conditions out there that can affect folks' thinking. So Alzheimer's disease, like I said, the most common, about 60, 80 to 80% of all dementias based on kind of depending on which sample you're looking at. And I think a lot of folks are pretty familiar with the clinical presentation of Alzheimer's disease. So most of these folks have pretty significant memory problems. They have trouble learning new information, retaining new information, and cues and reminders don't necessarily help trigger their recall. These folks also have naming problems. So that tip of the tongue feeling, right? Like I know what I'm talking about, but I can't find the word, can be fairly pronounced with some of these patients. Some of them have better abilities than others to compensate, right? Talk around, use a synonym or alternate word, but that kind of language retrieval system is impacted. We see executive dysfunction, so multitasking changes and visuospatial skills difficulties as well. As I'm sure you guys know, this is really impacting the medial temporal lobes. As you can see in the picture, kind of that part in the red box, you can see the differences, right? There's a lot of shrinkage, a lot of atrophy compared to a normal brain. There's a lot of Alzheimer's biomarkers that have come on the market, right? So in addition to MRIs and CSF testing, there's these new amyloid PET scans, there's these blood biomarkers that have come out as well. And then the treatments, right? So things like donepezil, memantine, but also these newly approved kind of amyloid targeting infusions, which are meant to sort of clear that amyloid buildup out of the brain and hopefully kind of reduce progression over time. Vascular dementias are sort of the next most common, making up about 15% of all dementia cases. And this really subsumes a number of different sort of causes. We can have vascular dementias related to stroke, such as what you can see in that the scan labeled B there in the middle of the screen, but also due to other sorts of cerebrovascular conditions that we know can affect the brain. So things like small vessel disease, changes in the very small blood vessels in the brain that can then affect your cognition. Same idea, things like cerebral amyloid angiopathy or CADASIL. With stroke, obviously the cognitive implications depend on exactly where in the brain the stroke happened. For some of these other types of things, what patients tend to exhibit is what we call a, quote, subcortical cognitive profile. They're having changes in some of these kind of central parts of the brain that you can see on the left side there, where kind of the white parts are in the middle. That's abnormal. We don't really want to see that. And so what that results in is kind of significant changes in slowed processing speed, executive dysfunction, and also a lot of memory inefficiencies. So really inefficient learning and a lot of benefit from cueing when trying to kind of retrieve memories. We also think about frontotemporal dementias, and these make up about 10 to 20% of all dementias. Leading cause of young onset dementia. When we think about young onset dementia, we're talking about folks who have developed dementia before the age of 65. And so for these patients, frontotemporal dementias or FTD are just as or even more common than things like Alzheimer's disease. For FTD in particular, there tends to be a lot of frequent misdiagnosis. These patients are often initially misdiagnosed, for example, as having psychiatric conditions or motor conditions, and we'll kind of talk about why in a minute. And so there can be like a 5 to 6 year delay between when symptoms start and when they're actually diagnosed. There's three main underlying pathologies. There's sort of like a tau-based pathology, a TDP43-based pathology, and an FUS pathology. Again, kind of beyond what we want to talk about today, but just to give you a sense of kind of what's at play with these disorders. About 40% of these patients have a documented family history of FTD or ALS. They're very kind of clinically related, so there's clearly a genetic component to this. And about 10 to 20% of these patients have these kind of known genetic mutations that will cause FTD or ALS. There's three big subtypes when we think about frontotemporal dementias. There's a behavioral variant, a primary progressive aphasia variant, which really affects the language systems, and then motor variants, which are much more rare and something we're really not going to talk about today. So when we think about behavioral variant FTD, these are folks who are experiencing pretty significant changes in mood, behavior, personality, because of the changes in the front part of their brain. That tends to be where the atrophy is centralized. So these patients may become very disinhibited. They can also develop apathy syndromes, kind of lose that motivation, that engagement, and that inertia, and it can develop inertia. And it can be pretty significant. Patients can lose the drive for things like, feeding, getting dressed, at some of the more extreme ends of things. Patients can lose sympathy, empathy, kind of those that social relationships can really change, theory of mind, perspective taking, even understanding like jokes and humor can really change. Patients can become perseverative, kind of develop more OCD types of behaviors. Hyperorality, kind of this desire to kind of put things in the mouth to eat, seeing dietary changes where they tend to eat too much or kind of have these unusual food cravings that they never used to have before. And we can also see cognitive changes too, particularly in some of these executive skills. Typically, we tend to see changes in mood and behavior before we see changes in cognition. So it's a little bit later in the disease process. When we think about primary progressive aphasias, there's a lot of information on the screen, but I think the takeaway point here is these are disorders that really affect language processing. These disorders kind of have three main categories. There's a semantic aphasia, which really means that somebody's losing their kind of knowledge of words, the word meanings, which obviously has a lot of implications for their ability to navigate life when they don't understand what's being said to them, nor can they communicate their needs. These folks kind of, a lot of the changes are occurring within the anterior temporal lobes, kind of the green parts that are lit up on the screen. There's also folks with what's called non-fluent aphasias. These folks have really slow, effortful speech. They might make grammatical errors. Telegraphic speech tends to be pretty common too. And some of these patients also develop what's called speech apraxias. And what that is difficulty with the motor programming involved in sort of producing speech. So if you think about it, speech is a very motorically complex task. You have to coordinate your lips, your mouth movements, your tongue movements, your breathing, and your body begins to have trouble sort of coordinating those types of things and efficiently and effectively producing speech. That said, their language comprehension is preserved. So their understanding of what's being said or what they're reading is perfectly intact. And then the third kind of category is logopenic. And these folks really have impaired speech and sound processing. So they have a lot of word finding hesitations, circumlocution. So they might talk around words rather than being able to sort of come up with the exact word that they're looking for, or even reverse phonemes. So instead of saying bat, they say tab. They're kind of reversing words in the moment. And they also have trouble both repeating and understanding sort of longer phrases, longer sentences. So all of these types of things can really obviously affect someone's ability to function day to day. The next category of things we tend to think about are called Lewy body dementias. And these are diseases that are associated with clumps of alpha-synuclein within the basal ganglia and really affect the dopamine system. So things like Parkinson's disease, dementia with Lewy bodies, multiple system atrophy, and other types of conditions have this underlying pathology. The risk factors for this are similar compared to other things, age, genetics, male, head injury. There's also some potential role for chronic exposures, particularly with things like Parkinson's. There's some interesting literature looking at protective factors, like the role of caffeine and smoking. This is one of the things that smoking is actually shown to have a benefit for, weirdly enough, and exercise. So in terms of Lewy body dementias, I just kind of want to talk about the two main ones, which is dementia with Lewy bodies, making about 5 to 15% of all dementias, and then Parkinson's disease dementia, making about 5% of dementias. And the key differentiation between these two things is really when motor symptoms occur in relation to the development of cognitive symptoms. So for folks with Parkinson's disease dementia, they've had years of Parkinsonian movement problems, and they oftentimes tend to be pretty disabled from their Parkinson's before the cognitive issues develop. With dementia with Lewy bodies, the motor and the cognitive symptoms come on board approximately at the same time or within about a year of each other. And it's really that differentiation in terms of timing that sort of clinically distinguishes these two disorders. And we'll kind of go through some of the other points on the slide now. So when we think about cognition, what really tends to be affected are some more of these executive skills, attention, visuospatial skills, memory retrieval. So they're not amnestic like Alzheimer's patients. It's really that slowed retrieval of memories, and speed. Language skills are rarely affected in these patients. And if you're seeing changes, sort of raises concerns regarding possible co-occurring conditions. These patients, particularly patients with dementia with Lewy bodies, are known for cognitive fluctuations. So their thinking can fluctuate quite a bit from day to day or even kind of within the hour. So fluctuating attention, fluctuating concentration, kind of these unexplained episodes of confusion or decreased responsiveness, sort of that don't make sense in the context of everything else that's going on for the patient. The Mayo Fluctuation Scale, which the questions are on the screen there, is one really great way to assess cognitive fluctuations quickly, right? So looking at drowsiness, lethargy, sleep patterns, or times when their thinking really seems to change before returning to baseline. Behavioral and neuropsychiatric changes are also incredibly common with these patients, particularly in folks with dementia with Lewy bodies. Visual hallucinations are incredibly common as sort of like a red flag symptom that this may be going on. For these patients, these hallucinations tend to be benign. They're not scary. They tend to be little children, little animals. So patients might say like, oh, do you see that little girl playing on the lawn outside or that cat in the corner? They're non-threatening, and patients typically don't have a lot of insight into them. Illusions can occur, so misperceptions, things like that. A sense of presence or passage, particularly in folks with more Parkinson's disease related conditions. You don't see a lot of auditory, tactile, or other types of hallucinations. Delusions are common, things like spousal infidelity, stealing, phantom boarder. So I think there's someone living in the attic or the basement. Or even things like Capgras syndrome can happen too, right? So this belief that my wife's been replaced by somebody that looks like my wife, but it's not my wife. Depression, anxiety, apathy are very heavy, are very strong in these populations, even compared to other like dementia groups, right? So even compared to Alzheimer's disease, you see higher rates of these neuropsychiatric conditions. Sleep changes are big, and REM sleep changes can really predate cognitive decline by decades for some folks. When we're thinking about REM sleep changes, we're really thinking about the sleep behavior disorder, so the acting out of dreams. We can see excessive daytime sleepiness, nocturnal disruptions, and also changes just in circadian rhythms. Folks are really having trouble just regulating sleep. And then, of course, the motor symptoms. So these Parkinsonian-like symptoms that I'm sure a lot of you have seen, right? Stiffness, rigidity, slowed gait, shuffling walk, falls, changes in posture, like the stoop gentleman on the slide. Tremor, particularly obviously common in Parkinson's disease, maybe less so in dementia with Lewy bodies. So when we think about these dementia conditions, they don't just affect the patient, right? They affect the caregivers and the family system around them. So we think about caregiving in general, excuse me, within the US, over 80% of the help provided to older adults comes from informal, untrained, and unpaired caregivers. So really relying on those family and friends. And a lot of people spend a lot of time, in caregiving roles. So one survey done recently by the Alzheimer's Association showed that their caregivers are spending almost 30 hours a week in unpaid caregiving roles. There's a lot of reasons why people provide care, right? There's a desire to keep someone with dementia at home. A lot of seniors really want to age in place, and so families want to honor that wish. For some folks, it's about wanting to remain close with that individual with dementia. I want to keep my relationship with them going. And then for others, it's a sense of obligation, right? Like I have to do this, either financially, we can't afford another choice, or, my mom took care of me when I was a kid. Now it's my turn to give that back to her. And caregivers, as I'm sure you guys know, they do everything, right? Caregivers can help with the IADLs, so the shopping, the meals, the transportation, the finances, the household chores, but also the basic activities too, right? Bathing, dressing, transferring, toileting. They're really hands-on caregiving. They're in there, they're doing that. They help with symptom management, so helping patients adhere to treatment recommendations, managing symptoms not just of dementia, but their other health conditions too. A lot of folks with dementia have other health problems that they're also managing, hypertension, cholesterol, diabetes, and so caregivers are helping with those types of things as well. Caregivers are doing a lot of coordination too, right? Like even if maybe they're not providing the direct hands-on care, but they're hiring the in-home services. They're making sure they're coming on time. They're making sure they're getting paid. And they also provide emotional support to the patient with dementia. Caregiving is stressful, right? I think we've seen this, maybe in our own lives, but even with patients and families that we've worked with too, right? So 70% of caregivers report that coordinating all this care is very stressful. navigating the healthcare system, finding the resources, and paying for it, right? The US healthcare system is very fragmented, very broken, and it is very challenging for folks to navigate. Despite that, only about half of caregivers have actually spoken about that issue with healthcare professionals or asked others for help. And healthcare professionals, right, we agree, right? A lot of us would say, like, yeah, the health system is not set up to help patients and families successfully navigate dementia care. So who are the caregivers? Most of these are women. About a third of them are 65 and up themselves, right? So they're dealing with their own health issues on top of caregiving. About 2/3 of these folks live with a person with dementia, and a quarter are sandwich caregivers. And I'm sure we've all heard this term, folks who are caring not just for the elderly parents, but also have kids at home, and they're trying to sort of balance the needs of both of those generations. We know 60% of caregivers are employed, and about 40% are caregiving without any other additional assistance from anyone else. So consequences of caregiving, it's very physically demanding, right? So almost 3/4 of caregivers are concerned about their own health. 27% are like delaying, skipping tasks to support their own health, whether skipping appointments or deferring, their annual, physical to a later time and point in time, not exercising, not eating as well. And 35% of folks really kind of directly relate their health as being more poor because of caregiving responsibilities. There's a lot of data out there showing that caregivers have higher rates of hypertension, heart disease, diabetes, hospitalization, ER visits compared to the general population. And it also has an emotional toll, right? A lot of these caregivers are describing themselves as being under high or very high levels of stress. About 30 to 40% sort of meet diagnostic criteria for depression. And one statistic I always like to point out is when we're looking at older caregivers, so caregivers who themselves are 65 and up, about a third of them kind of actively endorse SI. So something to kind of keep in mind as you're working with folks. About 40% also meet clinical criteria for diagnosis of anxiety. Caregiving also has financial impacts too. So the cost of caring for someone with dementia is expensive. It's about $400,000 over the lifetime, and 70% of that is borne by families. As a result, families cut back on other things, right? They cut back on their spending. They're cutting back on their savings due to these impressive costs. And like I said, about 60% of these caregivers are trying to balance caregiving with working. That impacts their role in the workplace, their ability to work, which then impacts their financial status, right? And so you kind of get stuck in this loop where caregivers are kind of getting pulled in multiple directions. The data on the slide there is from a very recent Alzheimer's Association survey looking at work impacts of for caregivers, both of people caregiving for folks with dementia in the purple bars, but also compared to caregivers for patients with other types of conditions like cancer or orthopedic conditions. How do they compare? And what we can see in particular for dementia caregivers is that they're kind of reporting less time available to work, right? They're going in late, they're leaving early, they're taking time off to attend to their caregiving responsibilities, more so than caregivers for these other populations. Caregivers are endorsing, kind of cutting back their hours, going from full-time to part-time, taking a leave in absence, or just stopping working entirely. A fair number of folks have turned down promotion or other kinds of like professional advancement because they don't feel like they can balance it all. And 7% of folks are like receiving formal warnings from their employer, about their performance or their attendance. And the same number of folks have kind of lost benefits, right? And we all know that benefits, having continued access to healthcare insurance, retirement benefits is really key sort of for stabilizing the family's financial situation for the future. So all this put together, we think about what's called caregiver burden. And that's really defined as like this physical, emotional, financial strain that's experienced by caregivers of individuals with chronic illness, not just depression, but other illnesses as well. And about 50 to 80% of caregivers really experience this clinically significant burden. There's lots of signs out there, right? So things like denial about the disease, its effect on the patient. I know mom's going to get better. Anger, anger they can't do the things they used to do. Like he knows how to get dressed. So why is he just being stubborn today? Things like depression, I just don't care anymore. I don't bother. Anxiety, about the future. What happens when they need more care than I can provide? Irritability, just leave me alone. I don't want to deal with it. Go away. Social withdrawal. You don't care about visiting with my friends anymore or going out to spend time with folks. Exhaustion. I'm just so tired. I can't focus on anything. Or even sleeplessness due to other concerns. So, what happens if I fall asleep and he wanders? Or he falls down the stairs or does something else unsafe? Can lead to cognitive issues, right? Trouble concentrating. I was so busy focusing on caregiving, I forgot my own appointment. Or health problems like we talked about, right? These sorts of things start to take a physical toll or even result in unhealthy behaviors like increased drinking or substance use. Like, I can't remember the last time I felt good. So what can we do, as mental health professionals? How can we work with these folks? And sort of first and foremost is you want to emphasize the importance of caring for the caregiver, right? We're so focused on caregiving that we neglect our own care. It's those metaphors, right? Like you can't pour from an empty cup, or when you're in an airplane, put on your own oxygen mask before you put on that of someone else. So how do we do that, right? It's really about emphasizing the importance of self-care from a number of different angles. So physically, right, staying healthy, diet, exercise, good sleep, getting your own medical care, managing emotions, whether that's just providing a listening ear, but even more formal in-office screens and referring caregivers for additional services, even if they're not directly your patient. Helping caregivers to renew their commitment too, right? So in the middle of a difficult caregiving day can be really easy to lose sight of why they wanted to be a caregiver in the first place. So encouraging them to say, take a pause, take a step back. Why did I do this? What are some of the positive aspects of caregiving? Things like gratitude journaling, right? Which I'm sure a lot of you have used in other situations can be really helpful for caregivers. Making time for themselves, that idea of me time and making it okay to do things they enjoy, to socialize, and to take advantage of things like respite care. When we think about support for caregivers, we know that building a support network is crucial, right? This idea of like it takes a village. And depending on the setting, they can sometimes require some help to build a team. Dementia is a partnership, right? That you have the dementia patient, but you have their caregivers, their family, their physicians, but also others. And we know that for caregivers, approaching a number of people with small requests can really help that burden. So we think about family, friends, making lists, discussing tasks that folks can help with, and being explicit, right? Even small things like, hey, can you run out and pick up this medication for me or mow the lawn for me? Take the patient for a walk for 10, 15 minutes. All these types of things can help out caregivers. Enlisting neighbors, right? They could be an extra set of eyes. Maybe they can visit, they can run errands, they can kind of watch locally and intervene. If you have a patient who's wandering and the neighbor sees them out, they can sort of be a support, help the patient, bring the patient back home. For example, kids who are doing caregiving from afar, having a set of eyes more locally who can really check in can be very helpful. But there's a lot of other resources out there too, right? Senior centers, support groups, professional caregivers. And we've seen these types of things really explode over the years, particularly things like adult day programs and geriatric case managers, case management just more generally, and a lot of national and community organizations. And we'll talk more about those in a couple of minutes. Other thing we can think about really is, the psychotherapy end of things. So if you have a patient that's a caregiver, how do you approach that in psychotherapy, right? Caregiving can involve a lot of really complex emotions. There's a lot of transitions. So decision making kind of moves, within a couple from shared to more unilateral. The emotional dynamics shift from this one of like equal partnership to more like protective management, right? Folks are losing emotional relationships, lack of intimacy, and even the quality of their relationships in the years prior can really impact the caregiving experience. So if I'm caring for my mom with dementia and we've had, the most loving, wonderful relationship for the last 50 years, that experience is going to be much different than somebody who's caring for a mother who maybe was abusive, right? And how does that kind of affect how one becomes a caregiver and how one executes one's caregiver role? So in that case, I think as therapists, it's really important to think about how we can help caregivers, heal, maintain, or even in some case, create new relationships with the person that they're caring for in the context of really that person's changing abilities. We know it's really important for caregivers to find joy and meaning in their relationships and stay as connected as they can be. So when we work with caregivers, I think first acknowledging that families need to prepare for relationship change. Um, and part of that is to really normalize relationship changes. So Taking a step back, just thinking about relationships in general, they're always fluid, even outside of the context of dementia. A couple might move from, dating to a committed married relationship. Dynamics shift in couples when they have kids, right? Change is normal, but we know that the type of change in dementia it's different, right? It's felt as a loss. It can be sad. It can be difficult, and it's okay. One thing that can really help maintain relationships is what's called pleasant activity scheduling, right? Kind of building, kind of making that intentional choice to foster that continued relationship. But there's a lot of really good data showing that it can reduce neuropsychiatric symptoms, both for the patient, but also some of the negative consequences that are associated with caregiving. And so what this often involves is really helping the caregiver think through what the patient may have liked before and how that might be compatible or maybe not with their changing abilities. So maybe somebody used to love to play Scrabble, but now they can only really sort the tiles. Maybe they used to have long, deep conversations, and now you more spend time looking through old pictures, right? And it's the caregiver who does need to take the lead in planning these types of activities, when to do it, ideally when the patient's going to be at their best. We also know that caregiving can involve this idea of ambiguous loss, right? The patient's still there, but they're different. You're losing these shared memories, shared conversations, and future plans, right? A lot of people have great plans for retirement, trips they want to do, activities they want to engage in, and now that's changing. We know guilt is a big thing for caregivers, right? Guilt around feeling responsible that they couldn't slow down progression, guilt around long-term care placement, guilt around taking time for themselves. Burnout's a real thing, compassion fatigue, this idea of sort of losing patience, right? Experiencing emotional numbness when all they've been doing is 24/7 care. And of course, navigating family conflicts. So we think about sort of kind of traditional psychotherapy approaches, and how we can take them and fit them into the caregiving kind of system. CBT, right? So focusing on changing negative thought patterns to reduce that stress and really help caregivers kind of reframe some of those difficult caregiving moments. So as one example, a caregiver is trying to feed the patient. They're repeatedly pushing that spoon away. They're getting agitated. So the caregiver has that automatic thought, right? They're doing this on purpose. They're just trying to make my life difficult. I'm a failure as a caregiver. So, and then you got those emotional and physical reactions that follow, right? Anger, guilt, some of like the racing heartbeat or exhaustion, and behavior. Maybe the caregiver snaps or storms out of the room. And so that CBT intervention really gets in there, challenges those automatic thought processes, right? Is it true? No, the patient has a disease. They really don't have the ability to kind of consciously manipulate or intentionally annoy you. Is the caregiver failing? No. We know that refusing food is a common symptom of dementia, and it's not really reflective of the caregiver's worth. So the goal of therapy, right, becomes to reframe the caregiver's perceptions into more of, this is the disease talking. This isn't my parent. Food refusal is normal. I'm doing the best I can as a caregiver, sort of helping them move towards a place of patience, acceptance instead of anger, can help them take that breath, step away, and try again later. Family systems therapy is really key as well, right? So dementia affects the family. And so really looking at communication patterns, relationship dynamics, and how to balance care duties among relatives too. Families may disagree on how best to care for patients, or they vary in their ability to provide help. Maybe they don't live nearby. Maybe they don't have the financial resources or other limitations that really impact their ability to assist with caregiving. The primary giver could feel resentful too. I'm the one doing all the hands-on care. No one's helping me. And so the role of the therapist is to really, see how they fall into these rigid roles, teach them how to express their needs, help redistribute some of those duties based on what each person realistically can do. Supportive psychotherapy too, this idea of the validating environment, right? To help people really express some of those very complex emotions. So as an example, got a husband caring for a wife with late stage Alzheimer's disease. She doesn't recognize him anymore. She accuses him of being a stranger, requires a lot of hands-on, kind of 24/7 care. He's feeling isolated, burned out, and physically spent, right? So if he's able to work with therapists, hopefully kind of start talking about some of those feelings that he really doesn't feel he can talk about with anyone else. Sometimes I wish she would just pass away so this would finally be over. Or like I feel like I'm mourning a ghost, but she's actually here. I can't grieve because she's sitting here right in front of me. Or I feel so lonely, but she's here. So how can I feel lonely when my wife is still here? And again, so that therapeutic intervention isn't about fixing those thoughts, but providing a space to express them, you know, that normalization, that validation. What you're feeling is called anticipatory grief. Wishing for an end to her suffering and yours doesn't make you a bad person. You're a grieving human being, kind of working with that weight of shame that a lot of caregivers provide or come with, excuse me, and then really accentuating strengths too. This idea of resilience, coping, you've shown your wife so much love, so much dignity, so much respect, over the past few years, allowing them again to have more of that self-compassion. Mindfulness interventions are huge, right? We know in a lot of stress-based interventions that meditation, present moment awareness can really help sort of downplay and reduce that emotional exhaustion. And then psychoeducation too. It's amazing to me how many dementia caregivers don't understand some of these symptoms, why patients are having them, and what to do about them. So when we think about strategies, some things I like to talk with patients and their families about is really these ideas, these frameworks for caregiving. Like, how do we approach caregiving day to day? There's a lot of different things out there. These are some of my favorites. The first one is 4 Rs: reassure, routine, reminisce, and redirect. So reassurance, dementia patients often experience confusion, anxiety, fear because of their cognitive issues. And the idea is obviously to alleviate these feelings through reassurance and provide a sense of comfort. So strategies we think about: speaking calmly, using those soothing tones; physical comfort, like holding hands, offering hugs, gentle touches, things like that to sort of physically provide a sense of comfort. Positive reinforcement is key too, encouraging, praising them for their efforts, no matter how small, boosting confidence, right? Self-esteem. And also ensuring that the living space is safe, it's familiar, right? So reducing clutter, adequate lighting, all these types of things can really minimize confusion and anxiety. We think about routine, right? The sense of predictability, security, familiar activities for all of us, consistent schedules can really help reduce confusion. So daily schedules, right? We do this at 9, this at 10, this at 11. Simple tasks, breaking things down into simple one-step types of things, making it easier for folks with dementia to engage in life. And again, this idea of maintaining consistency, both in the environment, but also in caregivers. It can be really difficult when you've got like a different caregiver in the house every day of the week for folks to have a sense of routine. We know reminiscing is really key for dementia patients too. They find it comforting, they find it enjoyable. It helps them connect with their memories, right? Provide a sense of identity, continuity. So different things, looking through photo albums, using those pictures to sort of cue off conversations about past people, past events, past places they've been, playing music from their past, storytelling, right? Encourage them to share memories from the past and really asking some of those open-ended questions to prompt some of those memories. Even things like memory boxes, right? So you kind of have that box with sentimental items like letters and souvenirs and other keepsakes, again, to serve as sort of like a trigger to starting those conversations. And then redirection, important too. This idea of distraction, when someone's behavior is starting to get escalated, move into a calm environment, shifting their focus, really avoiding that sense of argument and confrontation. Another framework that a lot of folks find to be helpful is called the 3 Aids. And they're really ways to sort of set yourself up for successful daily interactions. So thinking about approach, so how you approach the patient, the way you present yourself really sets a tone for all those interactions. So making sure you're at their level, you're standing or sitting at eye level, making sure you have eye contact, right? Making sure they're focused on you before you engage in a conversation or a task. Smiling, nonverbals, smile, show you're a warm, friendly, safe person through the nonverbal communications. Things like saying your name and your relationships. Instead of just saying, good morning, say, hey, Dad, it's Beth. How are you doing today? Again, kind of just speaking slowly, reassuring voices, and give them time, right? So give them time to process what you're saying and respond. Assessing the situation is key, right? So before doing anything else, figuring out what's causing kind of their current mood, current behavior, or their current needs. So looking around the environment, are there loud noises, uncomfortable temperatures, weird shadows on the wall that could be provoking them? Looking for physical discomfort. Are they hungry? Are they thirsty? Do they seem like they're in pain? Or just more generally, what do their emotions seem like? Do they seem scared or overwhelmed, frustrated? Kind of looking at their nonverbals to sort of assess what's going on. Or look at the task they're trying to do, right? Is it too complicated? Is it going too fast? And might that be leading to some agitation? And then, of course, assist, right? Once you understand their needs, help in a way that respects their abilities, right? And still promotes independence. So helping, not saying you'll do the task for them, but helping them break it down into smaller, easier steps. Offering simple choices rather than open-ended questions. So on a basic level, instead of saying, hey, what do you want for breakfast? Say, do you want cereal or toast for breakfast? So kind of, again, allowing them some autonomy, but making it easier for them to sort of express it. This idea of sort of validating their feelings instead of arguing, correcting the reality, and this idea of redirection again. So kind of moving them, kind of assist them to move to something more pleasant. Another broad technique is called the 3-time principles. So obviously take your time. Don't tell them something when you're rushing out the door, and don't tell them 5 minutes before you need to leave that now's the time you need to get ready. Saying and doing one thing at a time. So speak slowly, clearly, give one-step directions instead of saying, hey, go upstairs, brush your teeth, grab your coat, and meet me at the door. That's too much, right? So one step at a time. And again, this idea of offering timely praise, avoiding criticism and looking for things to offer genuine praise for. And then behavior analysis, kind of this ABCs that we're all pretty familiar with. We're looking at antecedents, behaviors, and consequence, and sort of seeing what we can adjust there to sort of improve behaviors day to day. Strategies are also really important too. I spend a lot of time talking with patients and their families about these types of things because yes, these patients are experiencing cognitive changes. What do we do about it? Memory aids are key, right? Whiteboards, kind of having a whiteboard on the fridge or the kitchen wall that kind of has the day's schedule planned, right? Electronic reminders for folks who like phones, right, can be really helpful. A memory place to kind of keep, that bowl by the door to keep the keys and the wallet in, or a single notebook to write stuff down instead of scattering Post-its all over the house. Familiar routines, kind of keep an eye on wandering, right? So things like stop signs on the doors, alarms if doors are opened, identifying jewelry tracking devices, or like an ID card to put in their wallet that says, hey, I have cognitive issues, please call so-and-so, if I need help. Managing language problems, so checking hearing is a really big one. It's amazing how that can really affect people's function day to day. Using pictures and labels, right? So for folks who are having some language changes, building in the nonverbals, kind of in the kitchen cabinets, labeling them with pictures of what goes in the cabinet can really help a lot of frustration. And managing attention executive issues too. So reducing distractions, overstimulation, again, making sure you have their full attention before you start speaking to them. Short, simple statements, and again, one step at a time. Emotional symptoms management is really key. Depression, anxiety, other neuropsychiatric symptoms are really common in dementia. Obviously consulting with physicians, particularly if there's sudden changes in behavior. So things like drug side effects, discomfort from other conditions. Maybe they're starting to develop a UTI, they're uncomfortable, and that's leading to some agitation. And again, things like uncorrected hearing and vision can also sort of lead to additional issues with confusion. Calming environments, calm language, nonverbal communications, redirection, managing sleep is really important. I think we all can relate to how we feel the next day after we haven't slept well. Layering in dementia on top of that sort of exacerbates those difficulties. Managing safety is important too. So things like gun safety, power tool safety, kitchen safety, right? Like, do you have a timer on the stove? Does the person with dementia cook unsupervised? Do you need to unplug the stove? Kind of walking through those types of things, knives, all the other appliances in the kitchen that have a danger risk to them. Driving safety is a huge one, right? Especially in Connecticut, like driving is independence. We don't really have that great of a public transportation system here. And so how to keep an eye on driving, keep not just the person with dementia safe, but everyone else on the road safe as well. Abusive behavior, and that goes in both directions. So making sure, one, that the dementia patient is well cared for, but also that the dementia patient is not abusive toward their caregivers. I've had a few patients where their behavior has been abusive towards their caregiver and has required sort of the calling in elder protective services for the safety of the caregiver. So again, sort of monitoring everyone's safety in the home is important. Future care planning is big too, right? So both medical and legal issues like living wills, healthcare proxies, power of attorneys, what's the difference between all these things? Estate planning. So we know long-term care in the US is very expensive. If a husband needs dementia care, how to preserve assets for the wife, right? And kind of making some of those informed decisions as a family, even things like protection from scams and poor judgment. So does the patient with dementia still have access to the bank accounts? Are they giving out their credit card and social security and all the phone numbers and all these things to people that call them? And then daily living, so not just driving, but where to live. And that can be a really difficult conversations for families. And I really encourage folks to really start planning early before you're in a crisis point and involve the person with dementia. They have opinions, they have desires, right? And I think that needs to be part of the conversation. As clinicians, most of the time, it's not our role to say, now is the time, or it can be, sorry. But it's a very personal decision, right? And every family's decision different when they think about, what kinds of services do we want in the home? When does it come to the point where we might need to think about placement? And typically what I talk to families about is really some questions to help them reflect and sort of think for themselves, and with a focus on the safety of self and others, right? So is the dementia patient leaving the stove on? Is wandering a problem? Are they having an increase in falls or like urinary accidents? Do they have mobility needs, right? Like they need help transferring, they need help walking. Are there problems with medication management, physical violence, aggression? Is the home unclean? Are there sanitary issues? Is there spoiled food in the fridge? Is their diet poor? Are they struggling to meet nutritional needs? Um, are they able to call 911 or respond appropriately in an emergency? So with a lot of my dementia patients, one of the questions I like to ask is, hey, you're having really bad chest pain. What would you do? And it's amazing how many folks either say, like, I know I need an ambulance, but they can't come up with 911. Or the folks that are just like, I'd wait till my sister got home. I'd just take an aspirin and go take a nap. And, those are things that are really red flags in terms of being able to maintain safety. Thinks about things like financial scams or suspiciousness, right? Like, are they unwilling to accept home-based services because there's a paranoia that's developed? Maybe it's more about quality of life. Are they lacking social stimulation, cognitive stimulation? Are they lonely? Or even thinking about the caregiver, right? Like, do they feel resentment? Are they burned out? So all things for families to think about when they're thinking about what level of care does my loved one need. We also think about planning for the caregiver's future. Caregiving can become all-consuming for some caregivers. At some point, they may place their loved one or their loved one may pass away. What does that mean for the caregiver? What is life going to look like post-caregiving? That's a huge transition, right? And so helping caregivers sort of think about what that's going to look like in advance becomes really important. What I want to do is just end with a few caregiving resources. There's a ton of stuff out there. These are some of my go-tos in terms of resources because families are often looking for places to start. And if you don't have the benefit of social work or case management services kind of where you're working, it can be hard to know where to point people. So the areas, Agencies on Aging, 211, caregiver.org and eldercare.gov are great resources for caregivers who are looking not just for support, but also to find actual services maybe to bring in the home. There's a lot of good caregiver kind of guides as well, and also specific organizations. Particular in Connecticut, the Alzheimer's Association is my go-to. Honestly, even for folks that don't have Alzheimer's disease, because they have honestly kind of the best array of services and are really versed at kind of what's available in the community for folks. Here at UConn, we offer a few kind of caregiver virtual education programs. They're all online, a lot of really good sort of webinar types of things. And some patients, if they have kind of true Medicare and not one of these Medicare Advantage plans, may also qualify for services through Medicare's Guide program, which involves a care coordinator, a lot of caregiver education support, respite services, but also a 24/7 support line.